Hello and welcome to another episode of A Conversation with Carl. Please remember to like, follow, and subscribe for the latest content. Today, I am honored to have Dr. Sara Hurvitz as my guest. Dr. Hurvitz is a medical oncologist and clinical research leader who serves as Senior Vice President of the Clinical Research Division at the Fred Hutch Cancer Center, which is an independent nonprofit organization. Dr. Hurvitz is an international expert and a leader in clinical and laboratory-based oncology research. Welcome, Dr. Sara Hurvitz, to the conversation.
Thank you so much. Really excited to be here.
So let's get started. And as someone who's on the cutting edge of breast cancer research, where are we currently in its treatment, and how does this differ from 5 years ago?
So many changes have happened in the last five to 10 years. If you go out even 10 years, gosh, it's been maybe 10 new drugs that have been FDA approved. And in the last 5 years, we've seen a number of approvals of therapies that are really improving outcomes for patients. We are seeing that the majority of patients diagnosed with breast cancer are cured of the disease because it's caught early enough. But not all patients. It still remains the number one cancer diagnosis in women in the United States and the number two cause of cancer-related deaths in women. So we still have work to do, even though we are seeing a lot of improvements in the way that we're able to treat the disease.
When you say it's the number two killer, are we finding more cancers or are we just catching them? Because of and I'm trying to figure out how to ask my question because it seems like there's a lot of women still getting breast cancer. Are more people getting it, or are they being diagnosed earlier?
You know, there have been variations in the diagnosis in terms of increases in diagnosis with implementation of routine screening mammography. Patients are caught with breast cancer. And so we do see an uptick in that over time slightly with the implementation of screening. But the death rate has remained somewhere around 40,000 women a year in the last, few recent years. So even though we do catch it in more women because of screening, the mortality associated with it remains the number two cancer killer. And I think what we're seeing actually is that breast cancer isn't just one disease. It's a compilation of different diseases. There are different subtypes or different flavors of breast cancer. The most common subtype is driven by the female hormones, estrogen and those hormones, and that we are seeing significant advances in the way that we can treat it. Another subtype called HER2 positive breast cancer, we know what's sort of causing and driving that cancer to be very aggressive, and we have therapies that specifically target it. And for that reason, we're seeing the mortality rate significantly decline over time with the implementation of these new therapies. But another subtype of breast cancer called triple negative that doesn't have hormone receptors or HER2 is more challenging to treat. And that's where a lot of our attention is now in the research realm.
One of your specializations is stem cell therapy and transplantation. Can you give us some insight into that?
Stem cell therapy, there's a lot of terms that get sort of commingled, even though they're fairly similar. When we talk about stem cell transplantation or bone marrow transplants, we're talking about giving patients really, really, really intense levels of chemotherapy that sort of wipes out their bone marrow and then replacing it with stem cells that we'd collected before that was given. And that is a form of treatment that my center is really very famous for because it was invented at the Fred Hutch. But that treatment is really used for blood malignancies like leukemias and lymphomas. They did test it in the 90s for breast cancer to see if you could give just massive amounts of chemotherapy and then rescue the patient's bone marrow by giving back those stem cells to repopulate it. And it actually didn't improve outcomes for patients with breast cancer. So that's not a form of therapy we use. And there's an important lesson from that, and that is giving a patient just everything that we have, even the kitchen sink, doesn't necessarily lead to a cure in breast cancer. Breast cancer, because it's so mixed, it's so heterogeneous, we have to go after what is causing that cancer to grow and divide. a little bit more in a more elegant and nuanced way. And so that's when we get into the targeted field, which is what I'm talking about, where we're trying to figure out what makes that cancer cell different from normal cells. And can we use that information to specifically target that cancer cell? And if we could do that, then we could have a less toxic and more effective therapy available. And that's what we're seeing a lot of now in the last several years as those types of therapies being developed.
And when we're talking about triple negative, where these cancers are coming from, are they coming from, I would say, like products that we're using, or are they coming from genes, the way our bodies are built? Or do we not know that
Yeah,
yet?
that's the big question that you're hitting on right there. First of all, triple negative breast cancer is not defined by what it is yet. It's defined by what it's not. It's not positive for the two hormone receptors and it's not positive for HER2. So we call it triple negative. That's not a very elegant way to subclassify cancers. So some triple negative breast cancers we know are linked to genes that mom or dad gives us. Those are called germline genetic mutations. A famous one is the BRCA mutation. I think it got a lot of press when Angelina Jolie announced publicly that she was a carrier of this mutation and she had mastectomies to prevent breast cancer. Well, sometimes these genes are associated with triple negative breast cancer, but that's not the majority. The majority of triple negative breast cancer, we're really not sure what causes it. We do know that younger women have a higher chance of developing it. We know that Black women are more at risk of developing triple negative breast cancer, but we don't know really what it is that causes that first cancer cell to behave abnormally and become cancerous. That's an area that's being really studied.
And then how do we figure that out? If I open up a newspaper or read articles, it's like, don't drink from plastic. This could cause cancer. That can cause cancer. What can I do?
Yeah, I mean, the environmental factors is certainly something that we all consider as possibly being related to the development of many cancers. I think to figure it out, we need a compilation of scientists. We need scientists who study big population data and look at exposures. There was this study done, gosh, 20 years, 30 years ago called the Women's Health Initiative, that was actually it was run across the country where women all enrolled and they filled out surveys about their lifestyle and what their exposures were and whether they drank and whether they smoked and whether they took hormones. And they followed these women over time to see what happened to them. Did they have heart disease? Did they get cancer? And we noticed that women taking certain kinds of hormone replacement therapy were developing breast cancer at a higher rate. So we were able to, infer that that meant that these hormones maybe were leading to an increased risk. So those kinds of large population studies are very helpful for us understanding the genesis of disease like cancer. I imagine AI is going to become a tool that's used widely to help us gather data in large populations like that and help us understand how our environment is impacting cancer development. But we also need our bench scientists, our laboratory-based scientists who are studying breast cancers under the microscope and studying the genes and the proteins and how the cancer is actually caused and how to best treat it. It can't just be one approach to help us figure it out. It's a multifaceted approach.
When people say they have cancer, it's everyone's story is different. And I'm not an expert in this. It seems like everyone has a different type of cancer. So what works for one person isn't going to work for necessarily another person. So how do you target therapies that are now used to treat breast cancer?
Yeah, it's a really good point because I think what you're hitting on is cancer is not one disease. That's why when we say, why isn't there a cure for cancer? It's like saying, why isn't there a cure for infection? Right? Because there's millions of infections and they're all different. There's viruses and bacteria. And so it's sort of this umbrella term that we use, but you're right. They're all very distinct diseases. Some of them share, um, molecular pathways a treatment for one cancer, for example, endometrial cancer, may actually work for breast cancer, but they are distinct diseases for the most part. In breast cancer, I sort of alluded to this. The work has been, for I would say now, 100 years, really in the last 50 years, an explosion of scientific discovery has happened, really understanding the various subtypes of breast cancer. And I think we understand what's driving breast cancer at a pretty fundamental level in about 85% of breast cancers. And so because of that understanding, because of that research that was done in the laboratory that was funded through various sources, government funding, NIH, et cetera, that information was able to translate into the development of medicines that go after and kill the cancer cells specifically, kind of like a Trojan horse technology where the cancer treatment can find what's abnormal about that cancer cell and deliver chemo or treatment specifically to it. So I think it's pretty interesting.
Yeah, and we just touched on this a little bit about research. If you would read the newspaper, there's NIH is cutting studies. Is that happening, or are you guys still doing the same amount of research, or should we be scared that there's not enough research going on?
It's the funding to support this fundamental research that ultimately down the road, 5, 10 years later, leads to curative therapies has been cut. It's relatively insidious, although the NIH budget hasn't changed much in the last year. The way the funds are being allocated, the way that scientists are part of the peer review process is changing, and the amount of funding coming through to institutions has changed. Scientists are needing to rely on donors, philanthropic sources, foundations. I serve on a couple of foundations, and we've seen the number of applications for grant funding and quadruple because scientists aren't able to get the kind of NIH funding that they used to be able to rely on. So I do think I'm somebody who is a glass half full person. I'm very optimistic. I think oncologists have to be inherently optimistic, but I have to say I am concerned about the long-term implications this will have on our ability to be a leading force in cancer discovery in the United States. And because we've been such a leader in new therapies for cancer for so long, I'm concerned that the changes we are facing can have global implications long term. So I think it's important people be aware of that this is real, but are the scientists still doing their work? They are. They're having to be creative to find new ways to fund the work they're doing and live on a tighter budget.
It puts a lot of pressure because you guys become politicians now and not sitting in a lab, because every time they say a politician, once they get elected, they have to go fundraise. Puts pressure on Fred Hutch now because they have to go find funding, and it puts pressure on scientists such as yourself.
Yes. Yeah, I mean, we don't want to be politicians, nor am I saying anything politically here. It's just important for us to continue to receive the kind of funding we need to move the work forward.
We touched on this a little bit, but can you just explain the difference between double and triple negative diagnosis and what that means?
Sure. Yeah. So when we test a breast cancer, if a patient's been diagnosed with breast cancer, we test for 3 proteins in the cancer cells: estrogen receptor, progesterone receptor, and something called HER2. HER2. The estrogen and progesterone receptors collectively are called hormone receptors. So those are 2 receptors. And if one of them is positive, we call it hormone receptor positive. HER2 is a protein that's expressed on all the cells in our body. It was probably important at some point during embryonic development, the development of the heart, and we're not sure why we need HER2 on our cells as adults. But sometimes as a breast cancer is developing, there's way too much of that protein that's expressed on the cancer cell. super overexpressed. So instead of there being 100,000 receptors on the cell, there's a million. And that makes the cancer divide and grow really, really quickly and spread more quickly. And so that is something that we figured out how to target. So what we want to know when a patient's diagnosed is, do they have estrogen receptor and progesterone receptor, those two hormone receptors on the cell? Yes or no? Do they have overexpression of this HER2? No. If the answer to all three is no, then it's triple negative. If it's hormone receptor positive, ERPR positive, and HER2 negative, that's a class. And then if it's HER2 positive, some of those will have the hormones as well, and that would be triple positive or double positive, and some don't. So you can see how we kind of classify just based on the information about those three receptors.
I want to go back to immunotherapy because we talked about that for a little bit. During COVID, the vaccine, which helped accelerate the vaccine, the research on that was all about immunotherapies. Are immunotherapy still being looked at, and how does it play into research?
Immune therapy, which is therapy that specifically ramps up one's immune system to recognize cancer cell as bad, that has shown success in breast cancer and specifically triple negative breast cancer. So we now are able to give patients with early stage or late stage triple negative breast cancer some immune therapy. It's an antibody or protein that's infused that tells the cancer cell or tells the immune cells recognize the cancer as foreign, and we give it in combination with chemotherapy because that makes the cancer cells more recognizable as bad. And that is something that we are using in about 40% of women diagnosed with triple negative breast cancer that's late stage. And then in higher risk, early stage disease, we're able to use it for all women before they have their surgery.
And we touched on this a little bit about AI before, but AI seems so relevant today, and it's in every conversation that I have. How do you see AI playing a role in breast cancer detection and then also treatment?
It's such a great question. I think AI is going to touch every facet of this world, including the breast cancer world. You can imagine that when a person gets a mammogram, it has to be read by a radiologist, and some centers have hundreds and hundreds of mammograms done in a given time period. Radiologists, can be at some centers overwhelmed by the workload. And so there are AI tools to help the radiologist read. So they're not replacing the radiologist, but they're helping to identify those high risk abnormal mammograms. So the technology developed to make the radiologists more efficient and effective is underway. It's not necessarily being rolled out clinically as we speak, but that's something that is underway. We also have, when a patient's had a biopsy or has had the tumor removed from the breast, a pathologist has to look at that and see, is it benign? Is it malignant? And look at the features. So AI, I think, will be very useful in assisting the pathologist in their work, but not replacing the pathologist. When I see a patient in the clinic, sometimes I will sit with them for 30, 45 minutes and I will be explaining things to them. They will be telling me how they feel, what their symptoms are. They can be very long visits. I need to document all of what I said and what they said in a note. AI is something we're using now to help so that I'm not looking at my computer trying to transcribe everything that's being said, but I'm actually looking face to face with the patient while the technology is hearing what I'm doing. And then we have, of course, AI being utilized in the research realm to help us detect new targets for cancer therapy.
When I go to the doctor now, he'll take out his phone and he'll say,
Yes,
AI is going to record this. Is that okay? And I'm like, that's
yes,
fine. But I do notice that my doctor's now looking at me, not writing
yes.
stuff down.
Yes,
So
yes.
my doctor
It's
is, yeah.
refreshing, right? Back to the doctor-patient relationship.
And then how I'll talk about like radical mastectomies used to be a typical treatment, but that doesn't seem like that is happening today. It seems you'll have lumpectomies.
It's such a tremendous story, actually. Radical mastectomies were started by someone called Sir William Halsted, a surgeon back in the 80s, invented this surgery which removed the entire breast, all the lymph nodes in the region, some of the muscle. I mean, it was just terrible. And actually, Betty Ford had a radical mastectomy in 1970 for breast cancer. It was never shown scientifically that removing all that tissue and all those nodes was improving outcomes until a man named Bernie Fisher came along in the 1950s. And Bernie did a randomized trial where volunteer women who were diagnosed with breast cancer volunteered to be a part of a study where they would either do the radical mastectomy or they'd be assigned to a modified radical mastectomy, which was less severe. It left some of the lymph nodes and tissue. And he showed there was no difference in how long the women survived or their recurrence rates. So he continued to push that envelope and did something called a lumpectomy. Where he removed just the tumor and some normal tissue around the tumor, leaving the breast intact, and showed that if you did that lumpectomy and followed it by some local radiation, you had the same recurrence rates and long-term survival as someone who had a mastectomy. He, a surgeon, was also the one who said there's some cancers that are really, really tiny, but they metastasize, even though the lymph nodes are clear and the tumor was small. And there are other ones that are large when we find them, but they've never metastasized. So biologically, there are differences in the types of tumors. We weren't testing hormone receptors or HER2 at that time. And he said, well, maybe these really high risk ones, we could give a little bit of chemo, some treatment or hormone therapy later. And he actually showed that giving the medicine therapy is what began to really impact how long patients lived and the cure rates. So as our medicines have gotten better, our surgeries have become de-escalated, much more, I would say, less morbid, allowing women to save their breasts without sacrificing survival.
And then, is there a particular recent advancement or breakthrough that you're currently studying that you're really excited about or hopeful about?
There are just so many right now. It's really amazing. I think there are going to be some real key advances in the use of immune therapy, not just for triple negative disease, but we've seen some promising evidence it may work in other subtypes. We have a new form of therapy called antibody drug conjugates, which are these antibodies that are like they home to the cancer cell, but they're carrying like on them, like in a backpack, chemo. So they deliver the chemo directly to the cancer cell. And we have several of these now available to women with different kinds of breast cancer. There are cancer vaccines that are being studied that actually train the immune system to recognize breast cancer cells before they've even become clinically evident. So can we prevent breast cancer with a vaccine? So I just think it's a really promising time. I said earlier I'm an optimist, but I think there's really good reason to be optimistic.
If cancer is different for everybody, how would the vaccine work? Because there's different types of cancers.
It's a super important question that scientists think about. There are a couple ways you can do it. You could take somebody who is diagnosed with a precancer, a very, very early stage cancer, and use those cancer cells, which are specific to the patient, to develop a vaccine to the cancer. Or you could develop a vaccine to a type of cancer and a protein that's expressed on the cancer for patients who are super high risk for getting that type of breast cancer. So there are different ways that scientists have figured out. I mean, all cancers are different, yes, but there are subgroups, just like we talked about. There are subgroups that are hormone receptor positive or HER2 positive, where we can sort of figure out what's going on with them, mutations in the cancers, et cetera, that could be gone after.
And do you think we're close to curing breast cancer? I know we're talking about 10 years from now and in the future. Where do you
I
think
think
we are?
subtypes. Yeah, some of
Yes.
our subtypes, I really do think. I mean, I have patients in my practice who I think are cured from HER2 positive breast cancer. They receive some HER2 directed therapy for widespread metastatic breast cancer and have never had it come back after treatment. I have some patients in my practice who have received therapy, newer therapies for their hormone receptor positive metastatic breast cancer, who I think may be cured. The trick is knowing when a patient with breast cancer is cured, because there's no test to tell us yet whether a patient has any cancer left in their body. That technology is getting really good, by the way, being able to detect circulating little tiny bits of tumor DNA in the blood. So maybe in the next 5 to 10 years, we'll be able to do a blood test. And if it's negative, we'll be able to tell a patient, you are clear of breast cancer. You don't need any more therapy. You are cured. I think getting to that point is going to be really important.
When you hear someone has a glioblastoma, right? They just have brain cancer, nothing else. They don't have other cancers in the body. When you have breast cancer, does that come with other cancers in the body, or is it just breast cancer?
So, two answers to that question. A woman who has been diagnosed with breast cancer has a higher risk of being diagnosed with other kinds of cancers, like uterine cancer, colon cancer, etc. So screening for those cancer, colon cancer moves up a little earlier. But I think what your question is when a patient has brain cancer, it pretty much stays in the brain. Whereas with breast cancer, the risk is that those cancer cells can escape the breast through the blood vessels before the breast cancer is even detected and can sort of hang out in the bone marrow, in the liver, in the lungs, not visible by scan, not detectable by a blood test at this point. And 5, 10, 15, 20 years later, a mass develops, is picked up on routine imaging or because of a complaint. And when you biopsy, it's the same breast cancer in the liver. That's called metastatic breast cancer to the liver. It's not liver cancer, it's the breast cancer that moved to that area and set up shop. So that's why we give medicine therapy to patients around the time of their diagnosis, even for stage 1 breast cancer, because we want to avoid or reduce the risk of having that metastatic event later.
Okay. And as we wrap up, is there anything that I should have asked you that I did not ask you?
You asked a lot of good questions.
You seem so
Yeah.
positive, and you seem like in a world where I feel it would be very depressing, you seem very cheery. I would love you to be my doctor if I had a cancer because you just seem like you come in there with a cheery disposition. And I think it's very hard when you're dealing with sad and scary moments.
It is.
When,
It is a scary. It's terrifying for the patients going through it. I have to say that I get so much energy from my patients, from the relationship I'm able to develop with them. When I was deciding in medical school what subspecialist, what kind of doctor I wanted to be, I kept getting drawn back to oncology because of that really special relationship you have with patients. It cuts through the superficial almost immediately. And you're talking about what a woman's or man's goals are in life and their quality of life and what they value. And I love teaching. And so I love explaining things to patients and sharing decisions with patients. My parents grew up in an era where when the doctor walked in the room, they stood up and, were very, would do whatever they told them to do. And I don't think that we're in an era where that works anymore. I think patients need to be, and maybe that's what I would say. The one thing you didn't ask is if a patient's diagnosed with any serious illness, I think it's really important for patients to feel empowered, to advocate for themselves, to bring a friend or loved one with them to the visit, to ask questions. They have the right to sharing in the decisions that they're making about their health.
yeah, a doctor makes all the difference. And I'll say when my daughter was diagnosed with epilepsy and she had a seizure and we were in the hospital and she was going to camp in 2 weeks. And the doctor said at the end, any questions? And my daughter said, yes, I have one. And we all looked at her thinking, what was she going to ask? And she said, can I go to camp? And the doctor said, yes, you can go to camp. And he said, you're just going to have to be careful and you're going to be able to do everything everybody else does, but you just have something to pay attention to that's going to be a little different. And I think that led us. That's the way we led afterwards. Otherwise, I think if the doctor would have said, oh, you can't do anything, we would have been like hiding.
Right. Right.
So
Right.
it made all the difference was how the neurologist approached it with us. So
Right.
yes,
Absolutely.
I just throw that story in there.
I love it. I love it that it tells the story of the kind of relationship you wanna have with your doctor. It's,
Yes. Yeah. So Dr. Sara Hurvitz, thank you so much for joining me today. Thank you out there for listening. Let me know what you think. Put your thoughts in the comment section. And until next time, everyone, be safe.